All right, hello everyone. We are in the peripheral nervous system. So this is going to be, I believe, part 4 in your discussions on campus. I believe it should be titled Chapter 13, PNS, Part 4. The PowerPoint B was broken up into 2 sections. So that's where we have the 2 and 3, and this is our 4. We should be able to get through this one in one full presentation. So it should just be part 4. So just wanted to clarify where we are in the PNS. We're going to try to move through this since we spend a lot of time in 11 and 12, and hopefully it pays off for the rest of the chapters. I've never spent this much time before on 2 chapters or 3 chapters before, but we really dug in here. So I'm going to try to move through this and focus on some of the main points. So that's, if you see me kind of moving fast, that is the reason why. So we are now in spinal nerves. We're already past cranial nerves, and we want to take a look at this. We have 31 pairs of spinal nerves. Okay, this information, I'm going to show it to you. I'm going to move past these 2 slides. These 2 slides, it's this right here. This is what it translates to. Make sure you know your ranges. For example, cervical nerves. Oh, let's go back. Cervical nerves, C1, C8, thoracic nerves, and so forth. Also, make sure that you understand these anatomical locations and the names of them. This will definitely be in your lab exam 13, right? So just please make sure we know that. Now, here's something of importance. We're talking about nerves. Nerves have to connect to something. In the case of spinal nerves, they're going to connect to the spinal cord via 2 roots. What are these 2 roots and what are their differences? The 2 roots are going to be ventral roots, dorsal roots. And the difference between them is that the ventral root is a motor nerve or a fiber, we can call it that. And it's an efferent. Remember efferent, afferent, those are directions from going to brain or from brain. Dorsal roots, sensory, afferent, right? So just please keep those 2 roots in mind and the difference between them. Here we have in bold, keeping it bold, ventral root, dorsal root, and we know what the differences are between them. Still in spinal nerves, I want to just point out the dorsal, ramus, ventral ramus, meningeal branch, and of course, because of the things we've talked about in meninges and meningitis, and we're going to focus on that, and the rami. So these dorsal are going to be smaller, ventral larger, and the meningeal branch is going to be tiny branch that re-enters vertebral canal to innervate meninges and blood vessels. Here in terms of the rami, and I've looked up the pronunciation of that, and yes, it does sound like R-A-W-M-E, like rami, and that's the way it's pronounced. Contain autonomic nerve fibers that join ventral, rami, and thoracic regions. One of the things I do need to do, since I don't involve myself much in some of this, is some of the pronunciations of these. They could be people's last names sometimes. There's all sorts of different things that go into the play. And some of them have a lot of different origins, so Arabic origin, Latin origins. And so it can get tough, some of the medical terminology. It takes time to study that. And I hope some of you do. I'm in that process as well. So let's take a look at this here. I want to talk about some differences between roots and rami. Well, the difference between a root and rami is that each root is going to be sensory or motor, not the both. And that's why it says purely sensory or motor. Rami can be both. Rami can be sensory and motor. So that's pretty cool that you can do that. Cervical plexus in the neck. Well, believe it or not, we are talking about nerves and we're talking about the peripheral system. So, hey, what's communicating? Where are we getting our information from our integumentary system? Let's say skin of neck or things like that. Where are we getting this from? So cervical plexus, that's going to be a major area in which we're going to be able to get some feedback from. So innervate skin of neck, ear, back of head, shoulders. The phrenic nerve. We're going to be looking into that, and it's a major motor. It's going to be involved in action, and it has sensory nerve of the diaphragm. We're going to get into a clinical. We're going to be talking about what happens if this particular nerve gets damaged, has a lesions, has some degradation, gets cut. What will happen? It runs from C3 to C5. So here we're taking a look at the phrenic nerve, and we see it from up here, C3, C4, and C5 areas. Now, in case we haven't discovered this or heard of it, well, hiccups are a direct result of a diaphragm spazzing or spasms. So because of that, it's causing that hiccup. Now, let's add something else to it. Some of you may have known this. Let's go in a little more in depth. Well, irritation of the phrenic nerve causes spasms of the diaphragm and also hiccups. Wow, that's pretty interesting. If you have nerves in this particular area, like C3, C5 region of the spinal cord, those regions that I told you, and if you have lesions or something's happening, degradation of the nerve, it was hit, trauma, something like that, it can cause respiratory arrest because the diaphragm isn't working. You need your diaphragm to function in order to breathe. So you have respiratory arrest. Some individuals may require respirators to stay alive. So they're going to need to have air forced into their lungs. And that's an unfortunate situation. Let's see. Let's take a look at here. We're going to be looking at the brachial plexus. Now, this can get broken up into two divisions. We also have our roots, our trunks, posterior divisions, anterior divisions. That's kind of what I want to point out here. So the brachial plexus, make sure that you know that it's broken up into four major branches, right? Roots, trunks, and its divisions. And you also have your cords. Now, what is confusing here, it says four. Within the division, they're showing you the anterior and posterior. Don't get confused. When you look at this image that I'm going to show you, it is not showing you, where am I? What the? Time out. There. You look at that and you see, okay, I see my four. No, no, no. These are not your four. These are one. So you have your roots, trunks, division, and your chords. So make sure we know that. Am I sharing screen? Nope.
Yes, you were.
Okay, I was sharing
Yes,
screen.
you are.
Okay, great. No, it's because I got a message from someone says I don't see anything. So I'm like, oh.
I don't see you screen sharing. I just see you.
Not anymore.
Yeah, not anymore because I'm talking to you. Yeah. But just wanted to stop. I saw a little as on the side while I was communicating. My screen's just in PowerPoint presentation. Saw something flashing, so I stopped it just to see what was going on. And I saw the message, and I just wanted to check up to see if things were going okay. All right, so we'll get back to it. So again, just don't get tripped up here because this is the way it goes. This is it says four main branches, right? Well, it's going to be roots, trunks. This is one. And your chords. That's your four. Please, again, just make sure you don't get tripped up on that, right? Because of the divisions break up into two. Now, I'll get into the clinicals. Let's get into injuries of the brachial plexus. They are common. They can happen. Okay, I was just saw another chat, so just checking it. Just want to make sure it's functioning. All right, injuries of brachial plexus are common. So these are severe injuries can weaken or paralyze the entire limb. So make sure we have this in mind. So what kind of injuries are we, or what type of situations? We do see this happen sometimes in football when someone's running. It's kind of, to me, it's kind of a weak play on someone's behalf of the tackler, who someone's running it and they grab the arm and they kind of like dig their heels in and then they kind of move and they swing the individual back. Yes, brachial plexus can get really hurt on that, and it could really affect the entire upper limb, and they may not even be able to use it. Maybe some therapy over some time. So that's something that can happen. Now, an injury to the median nerve, that's like the pincher grasp. So you have your index finger and your thumb, right? And to grab objects, that can be an issue with the median nerve. And on that same topic of having issues with control, let's say, of our fingers, one could be carpal tunnel syndrome. That is the median nerve. It's been compressed. So there's a lot of ergonomics that go into place. Sometimes also, unfortunately, individuals that may have experienced an unfortunate event and cut themselves in the wrist area may never recover the median nerve and may lack mobility of their hands. It can happen. So just keep that in mind. Also, remember ergonomics, how you sit is important. How you sit is very important. We as Americans, most of us sit a lot. And that is an important way, one of the ways that we hurt our backs. And make sure we understand that. I took an entire training course, and not here, they don't offer that here, but when I was working somewhere else, they realized that, wait a minute, we're paying a lot of money on insurance for people with back problems, and you're doing research and you're writing papers and you're writing grants. They said, why don't we teach people how to sit right, lower their chairs right? And all that stuff is called ergonomics. And sometimes improper ergonomics affects carpal tunnel. And that's what I wanted to share with you. That's the little brief thing. It's very important. Now, the ulnar nerve, this one's very, very vulnerable to injury. So in this particular case, you can have muscular atrophy. It says muscle. I usually just say muscular atrophy. Muscle atrophy is the same thing. Again, individual may struggle gripping things. They just can't grasp that. It can result in some sort of contortion known as the claw hand, something like that. It can hurt. And it's very painful. It can occur. It can occur in individuals even in of younger ages too. Doesn't mean that's just older people. So just also, that's something that one might want to keep in mind. Something known as a wrist drop. Wrist drop, radial nerve. So trauma to the radial nerve results in a wrist drop. So inability to extend the hand at wrist. How can this happen? How in the world would this happen? Well, believe it or not, improper use of a crutch can compress the radial nerve and impair its blood supply. So you need blood supply. We constantly need blood supply in order to have this nice homeostasis balance taking place. And blood is super important, making ATP, sending all these nutrients, sending the stuff needed through connective tissues and all this great, amazing stuff. And using crutches improperly, it can be something that can affect people. So if you are going to be in the human health field, please take time. Please take time to educate people on the proper usage of crutches. Really. Because you can just have someone coming back with another problem. So just try to make sure that you educate them on that. Especially if the person's a little bit maybe on the heavier side, you may want to make definite sure that you are talking to someone about the proper usage of that. But it can happen to anyone. Just some people are more prone to it than others. And weight is a factor, believe it or not. Something known as Saturday night paralysis. So someone goes out, has a little bit more drinks than they should have. They fall asleep with an arm like kind of draped over the back of a chair or sofa, and it cuts off blood supply of the radial nerve. Yeah, it's not something that's going, it's not like the crutch situation, because this could be months and months of chronic events cutting off blood supply, maybe for long durations of time. Yes, this one's a long duration of time of sleep, but it's not something that's going to be chronic, like improper use of a crutch. So yes, this can occur and usually recovers over time. I want to talk about a little bit about lumbar plexus. So we're going to get into our L1, L4, and get into the femoral nerve. So here we're looking at innervates of quadriceps and skin of the anterior thigh, medial surface of leg. So femoral nerve, and we're going to be looking at some other things. We're going to slowly get into even your sciatic as we move lower and lower and lower. These images can, I hesitate, a little FYI for you. I might just pick this one here in a lab exam, gonna be honest with you. And the reason is that it can get a little tricky pointing the arrows and gets a little kind of mixed up. Where are we? What am I doing? But I will probably point on something like this, because this is the largest one, and probably not use the other ones, to be really honest with you. It's just, I get into a situation where students like, well, it looks like you're pointing here, not pointing there. And I really don't like to get in those situations. So I just want to make sure that when I do a lab exam, that it's very distinct, that there is no room for error, that the student can't say like, well, it kind of looks like you're pointing here, because I just don't like arguing. So I just end up giving the points anyway. I just really don't like it. I have a lot more things to do. So I've learned to just avoid those technicalities and just focus on things that we can really, really make a difference and see. So just a little update in your lab exams when you're trying to study. And I know that we are pressed for time, but just getting you some insight and reasoning as to some of the why. Sarcal plexus, now we're getting into from L4 to S4. This area that serves like the buttocks, lower limb, pelvic structures along that area. Well, we then get into the sciatic nerve. This is gonna be the longest, the thickest nerve of the body. So innervates hamstring muscles, abductor magnus, most muscles in leg and foot. So when we're taking a look at that, it would be here. Fairly large, fairly thick. It's very, you can quite see it. It's fairly easy to observe. For example, right here. So you're taking a look at that, and that's a pretty darn long nerve, the sciatic nerve. Very, very long nerve, susceptible to a lot of injury. Again, ergonomics, a lot of different things take place into the sciatic nerve. So just wanted to point that out. So it's something that's I think all of us have heard of this before. Even in this, looking at this autopsy, we can see that that sciatic nerve is huge compared to anything else. So definitely that's a lab exam question. You cannot miss that. That's massive. And it runs a long distance. It's crazy. So when we're looking at spinal roots, remember that, right? The roots of lumbar plexus are compressed. We have gait problems. They can occur. So other symptoms are pain, numbness of the anterior thigh. Femoral nerve serves prime movers that flex the hip, okay, or extend knee. Well, if you have situation here, like it says damage can be caused by a herniated disc. That's not a good situation. So yeah, now we're kind of really getting into things that actually may have already affect some of us. So sciatica, a common problem is characterized by stabbing pain radiating over course of the sciatic nerve. Injury could be caused by a fall, disc herniation, or badly placed injection into the buttocks. That's something that can happen. Improper injections of the buttocks can cause injury. So again, make sure that individuals that you are doing that to, placing the injection, that you you don't hurt anybody. So it's just be conscious of that.
Is that the same nerve that hits when you get an epidural done?
I don't think so, because that we're talking about from the hip area running all the way down. So that's not where you get the epidural. I'm not sure exactly where that, does anybody know? But all I can tell you, it's not the sciatic nerve. I know that without a doubt. Anybody know where that's occurring? Which nerve that is? I don't know.
I'm not sure what nerve it is, but I know it's a nerve block from the lower region down.
Okay. But I don't think it would be this one that we're talking about. Maybe we'll reach it in the end of the presentation, but I don't think so. I do know it's risky, and you better know what you're doing.
I'm sorry.
Yes.
It says that it goes into the epidural space. The injection goes into the epidural space,
Yeah.
right up the membrane that protects your spinal cord.
Oh, okay. All right. Yeah, that's a risky move too. It's a risky move. It's something I like. How do you practice that? It's like flying a jet. You get more practice before you fly the jet, right? You get into a fake cockpit, but how do you do a fake epidural? I don't know. I'm sure there's techniques, but man, that I give credit to those who are very good at that, because
Don't you have to be a doctor for that, right?
I know, so I've heard of some RNs being able to pull it off. So
Oh wow, thank you.
yeah. Now maybe that wasn't supposed to be the case, but I do know that some were very successful at doing that. Yeah. So, yep.
I think the anesthesiologist does it.
Most of the time, the anesthesiologist does do that. That is correct.
We have nurse anesthetist, something like that. Nurse anesthetist.
Yep, that's correct. And remember, when you go into an RN like that, you can break off into different areas of specialties. So there are nurses that can do that. Sometimes you don't have your anesthesiologist at that moment there. If you're not at a very large hospital, he or she, anesthesiologist, may not be there. They already did blood work. They already looked at this. They already looked at that. Did all the dotted out all the T's and checked everything in terms of what you might need. But they're not there all the time.
Here in Del Rio, they don't have it.
I'm sorry. Can you repeat?
So here in Del Rio, we don't have any anesthesiologists. They're all nurse anesthetists, however you say that.
Yep, that's correct. Yeah, so nurses and anesthesiologists can do that as well. Good. One of the other things we're looking at here, since when we talk
Sir,
about, okay, hold on. Yes,
like nurses or like PAs?
nurses.
Okay.
Yep.
Like just with an RN certificate or BSN?
I think these are, BSN nurses. Right.
Okay.
This is the one situation that I saw. Yeah.
Okay.
Are we still
Thank you.
talking about the are we still on the same topic though?
Yeah,
Epidural.
yeah.
Okay, just making sure. All right. That's from what I understand. Yeah. And then you even get into like more nurse practitioners type of situation too. Right? So they're very knowledgeable. Very, very knowledgeable. Some of these nurses, they get their doctorates, you know, and then you have PAs. Some of the PAs are very knowledgeable. And so you got a lot of good people out there. Hopefully the trained well and they can do the job. So sometimes some anesthesiologists don't do the epidural. You have them in some situations they don't. Like they're like, nah, they do other things, but they don't do that. You know, that's another situation too. So it depends on from place to place. It depends. Depends on place to place. Okay. All right. Let me do a screen share. Good chat. Again, it can go down into foot, ankle. So foot and ankle cannot move at all. So the foot drops into a plantar flexion. So it's just a foot drop. That's not good. Again, some recovery of sciatic nerve injury is usually slow and incomplete. It can take a long, long time. So that's some of the situations that occurs with sciatic. So we're looking at all these different situations that can happen. And we're getting close to this. Hilton's law. I want to just point this out. Any nerve serving a muscle that produces movement at a joint also innervates that joint and skin over the joint. So that's Hilton's law. Just make sure we know that one when we're talking about nerve, any nerve serving a muscle. So this was one of our short presentations so far that we've had in in this entire course. The other presentation before this, I think, was like 38 slides. This one was 50. Normally our slides are 80 and 80 plus, which really takes us a while to get through it. So I'm going to stop it here on this particular presentation.